Welcome to a new weekly series of webinars every Thursday at 5 p.m. Eastern Time, Miami time. So I'm Jacques Morcos, professor and co-chair of the Department of Neurosurgery and Otolaryngology. I direct skull base and cerebrovascular surgery. And I am delighted to have as co-directors the following four co-directors: Carolina Benjamin in neurosurgery, specializing in brain tumor and skull base surgery at the University of Miami; Michael Ivan, also in the Department of Neurosurgery, Director of Research at the Brain Tumor Initiative, specializing in brain tumor, skull base, and epilepsy surgery, as well as Bobby Stark and Eric Peterson. Bobby is a co-director of endovascular neurosurgery, Director of Endovascular Research, and Eric is Director of Endovascular Neurosurgery at the University of Miami. Well, we are in Miami, Florida. You can see our beautiful city. You can see our medical complex and the two main hospitals where we work, University of Miami Hospital and Jackson Memorial Hospital. We are a high volume tertiary referral center, regionally, nationally, from Latin America and internationally, for cerebrovascular skull-based diseases, among other diseases. We have a firm commitment to clinical research and educational missions. So this series of lectures will really focus on two things: cerebrovascular and skull base. A very brief word about those two programs. For the cerebrovascular program, we have three open vascular neurosurgeons, one of whom is a pure open, and two are duly trained endovascular neurosurgeons. We have an endovascular neurologist. We have 8 stroke neurologists. The skull base program is just too large to detail. Suffice it to say, you can see the numbers of neurosurgeons, neuro-otologists, head and neck surgeons, rhinologists, oculoplastic surgeons, neuro-ophthalmology, neuroendocrinology, radiation oncology, neuroradiology, and neuropathology. We have a weekly multidisciplinary conference. We've kind of called it the MOBS. It stands for Multi-Specialist of the Base of the Skull. And we have fun every Tuesday discussing complex cases. We have a brand new lab we call the Keynes Lab for anatomical dissections and teaching that we share with our ENT department. You can see the brand new facility there, along with the MISTY lab, which is the wet lab. So why hold this symposium? Well, the educational opportunities are diminishing, as you know, with the COVID-19 world. We have a global captive audience. We have non-traveling educators. Frankly, I'm not sure who needs these seminars more, the educators or the students. I think the educators are so used to travel and teach students, they're probably getting withdrawal. But more importantly, microneurosurgery should remain a vital component of educational curriculum and clinical practice. And skull-based surgery and open vascular surgery are very complementary disciplines. How so? Well, it's a symbiosis. It's not parasitism. As you can see from this Venn diagram, we're going to focus on the zones 1, 2, and 3 through these series that we're going to have every week. But of course, you can see it's a partnership with many other disciplines. The zone of intersection, that's zone 2 between vascular and skull base, it's very obvious why you have that. CV helps skull base in many ways. For example, ICA balloon test occlusion for tumors, pre-op tumor embolization, intra-op repair, bypass of injured arteries and veins during tumor resection, of course, microvascular skills, dissecting, manipulating, and respecting the brain. And the other way around too, skull base helps CV, appreciation of anatomy of surgical exposure. You all know Rothen's teachings. Is the exposure just enough, not enough? Or is there too much of it? Is it unnecessary? It's a toolbox of approaches to use that are commensurate with your comfort level and years of experience. Cases like this, you go from pre-op to post-op to remove a cavernous angioma, requires a detailed understanding of anatomy, the details of the far lateral approach to resect the cavernoma, drilling the posterior clinoid on a basilar tip aneurysm, dealing with the complex tumor with the petrous carotid wrapped in it, or at the bottom, exenterating cavernous sinus in a grade 2 meningioma. Just few examples of many, many more you will hopefully all see throughout this series over many weeks. Before I continue, a big thank you needs to go to Ingrid Menendez, our Administrative Director of Education Programs, Residency, Fellowship, and Medical Education. A big thank you to Roberto Suazo, Graphic Design Project Manager. Many thanks to Cristina Sotolongo, the Executive Director of Communications here at the University of Miami, and Ignacio Escalona, who is actually running this webinar right now, video production specialist. If you would like to connect with us and our educational activities, the top line you see is the link to our website of the Department of Neurosurgery to view what is coming up in the Zoom-posiums or symposium. You can connect with our with Ingrid Menendez for education and coordination. You can certainly contact me by email, and we have a departmental Instagram and Twitter. For example, these are the upcoming 12 sessions every Thursday. You can see them in detail through that link that I gave at the top of the previous slide. And there will be 12 more to go after that. Housekeeping instructions for tonight. Please, audience members, use the QA box to send your questions. The co-directors and panelists will help in selecting them for discussion. We are not offering CMEs yet. You will get a confirmation email in a few days documenting your participation. If you like these sessions, obviously share the links you have and the programs we are offering with your colleagues. I'd like to put a plug-in for another symposium that goes on every Wednesday that my partner Mike Ivan is directing, and I'm co-director with Rick Komotar. It's called the Miami Global Brain Tumor Symposium. It's every Wednesday, 5 p.m. Or he's already had 3 sessions next week. Wednesday is immunotherapy for brain tumors with Michael Lim. And as for next Thursday, again, I know it's confusing. It's Wednesday and Thursday. The next Thursday symposium, like this one, is on bypasses with Fadi Charbel for cerebral ischemia, Michael Lawton for aneurysms. Next, the panelists tonight. Paul Camarata, professor and chair at the Department of Neurosurgery, Kansas University in Kansas City, is joining us. Carlos David, neurosurgeon at Leahy Hospital and Medical Center in Burlington, Massachusetts. Anthony Wang, assistant professor of neurosurgery at UCLA in LA. And lastly, but certainly not least, Stacy Wolfe at Wake Forest School of Medicine, Winston-Salem, North Carolina. And most importantly, who are our 2 speakers tonight? Well, you will quickly realize, if you didn't already, I chose those 2 particularly because they are absolutely ageless. Like microsurgery, microneurosurgery should be ageless. They are surgical masters and educators and world authorities. The first one who will speak will be Daniel Barrow, Pamela Rollins Chair and Professor at Emory University Department of Neurosurgery, Chief of Neurosurgery at Emory University Hospital, Director of the Emory MBNA Stroke Center in Atlanta. There aren't enough things to say about Dan. He's been president of the board of neurosurgery. He's been president of the Academy, American Academy of Neurosurgery, an absolutely delightful, charismatic, extremely masterful surgeon. I'm sure I'm introducing somebody who you all know already. And after that is Robert Spetzler, who of course had been the chair at the BNI for more than 30 years and is now chair emeritus of neurosurgery and director emeritus of the BNI. Here he is standing back in 2012 after he had clipped his 6,000th aneurysm. And if I have to tell you who Robert Spetzler is in this symposium, you may be in the wrong symposium. So I have done too many introductions of my mentor, Robert Spetzler, over the years, and I can certainly spend another hour talking about him, but we're not going to do that tonight. I thank both of them for sharing this. So I'm going to stop sharing my screen now, and I'm going to ask Dan Barrow to share his screen and to start his presentation on anterior circulation aneurysms. Thank you, Dan. Go ahead. Make sure you are unmuted, Dan.
Can you hear me now?
Yes, now I can. We can.
Great. Wonderful. Well, thanks for that nice introduction. I think you were introducing my wife instead of me, and I'm sure Robert would have not minded if you'd gone on a little bit longer about him. I appreciate the opportunity to do this. I was asked to talk about the role of microsurgery for anterior circulation aneurysms in the current era. And I don't have any disclosures, unfortunately, no financial disclosures, but I do have a bias that I think is important to disclose. I'm often asked, like many of you, how do we train the next generation of neurosurgeons? I think that the components of a modern training program include the following. I think it's high volume. I think it's having an interdisciplinary team that works in a very collegial manner, having a skull-based lab, having a microdissection lab, but I also very importantly think it's having some faculty with a surgical bias. I don't mean a surgical bias that ignores evidence-based medicine, but a bias that recognizes that there is a fair amount of debate that is ongoing. I want to thank my co-speaker and my friend and also mentor, Robert Spetzler. This is a slide of his, but the debate is coiling superior to surgical therapy. We have 4 prospective randomized trials that have been done. ISAT demonstrated a benefit for endovascular therapy at 1 year, but not at 5 and not at 10 years. The BRAT study showed no difference at any time point. The Finnish study showed no difference. The Lee study showed no difference. And a matched control study from Canada showed that clipping was superior. So I think that, to quote my dear friend Robert Harbaugh, this is a shaky foundation on which to build a revolution in the treatment of ruptured aneurysms. And I do believe that there is remaining equipoise for a very large number of aneurysms, but we don't have clear evidence that there is a superior treatment. And I think that's what I refer to when I say there needs to be some faculty with somewhat of a surgical bias in order to train the next generation. There are patients and aneurysms that are not ideal for endovascular therapy. Young people with a long life expectancy, those that are not compliant, that might require dual antiplatelet therapy. And there are a large number of aneurysms for which I believe there is equipoise between surgical and endovascular therapy. And I'd like to kind of briefly go through those in that order. First of all, if a patient presents with a life-threatening or health-threatening intracerebral hemorrhage, they need surgery. It is completely illogical to take a patient like this and coil their aneurysm and then take them to surgery, or take them to surgery to take the clot out and then coil their aneurysm. But I've actually seen that happen. The only advantage of endovascular therapy is to avoid an operation. If the patient needs an operation, for God's sake, treat the aneurysm with a more durable treatment at the time of the operation. Many aneurysms that are large and with mass effect are better treated with surgical therapy to eliminate them on a permanent basis and immediately get rid of the mass effect. This is an example that we see commonly, a patient with an ophthalmic segment aneurysm that has optic nerve compression and visual loss. And certainly this can be treated with endovascular therapy, and sometimes decreasing the pulsations will help. But there's nothing more gratifying than clipping this aneurysm, documenting with ICG that it's that carotid is patent, and immediately decompressing the optic apparatus under direct vision and making sure the optic nerve remains healthy and not wait for the potential benefits of an endovascular therapy in a permanent and long-lasting, durable result. At the other end of the spectrum, there are aneurysms that are too small for endovascular therapy. This small carotid aneurysm that's shown here, this was in a patient who presented with a subarachnoid hemorrhage. And on the left side of the screen, you can see this very small carotid aneurysm, which was the source of the hemorrhage, but also a very small posteriorly directed basilar trunk aneurysm in the same patient, neither of which were suitable for endovascular therapy. So in this particular case, we did a large opening and directed our attention initially to the carotid aneurysm, which you can see is bleeding. It's the source of the bleeding and bleeds intraoperatively. And through the sylvian fissure, this aneurysm will be directly clipped, bleeding controlled. This clip put on more distally just to be sure that we're not compromising the anterior choroidal artery, because I really haven't seen it well. But now you can see the anterior choroidal artery, and putting a more proximal clip on to control the bleeding, after which I will remove the more distal clip and use it to clip the little dog ear that's left with good direct visualization of the anterior choroidal artery. Now, this is an aneurysm for which there really isn't a good endovascular option. You can see the anterior choroidal is filling on ICG, but the patient's also got a basilar tip aneurysm that is pointing posteriorly. So this is what I refer to as the half and half approach, where now we can go down and go subtemporally and see the oculomotor nerve, putting a stitch in the free edge of the tentorium, preferably not where the fourth nerve enters, and pulling back, which gives an extra few millimeters. And you can see this unruptured aneurysm on the basilar trunk, a small perforator densely adherent to the neck that is moved out of the way. The unruptured aneurysm can be clipped during the same procedure rather than putting the patient through another procedure at a later date. And so one operation, two different exposures to deal with both the ruptured and the unruptured aneurysm. And here's the intraoperative angiogram showing both of them clipped. Wide-necked aneurysms are another instance where endovascular therapy may not be ideal. There are tools that are being developed for wide-necked aneurysms, endovascular tools, but I would remind you that we also have surgical tools for wide-necked aneurysms. They're called aneurysm clips, and they come in all sizes and shapes and configurations, and oftentimes that is a better way of managing a wide-necked aneurysm like this anterior communicating aneurysm. Here you can see a temporary clip being put on the contralateral A1 and one on the ipsilateral A1. So we've partially trapped the aneurysm. It's deflated. And using fenestrated clips to encompass the fenestration encompassing the proximal part of the neck, because the closing pressure is higher more distally, that will obliterate the distal part of the neck. And we can now clip that portion of the aneurysm passing through the fenestration, and then use another fenestrated clip to clip that portion passing below the fenestration. So now with a series of clips, a technique that was originally described by Sugita, we can very nicely reconstruct the entire anterior communicating complex. Temporary clips are off. The ICG shows that both A2 segments are filling, and we have a durable, time-honored solution. And you can see the before and after angiograms showing the type of result that one can get using modern clips. Sometimes aneurysms have very complex configurations. It's very difficult to eliminate them with endovascular therapy. And again, one of the benefits of modern clips that come in all sizes and shapes and angles with high closing pressures is that we can reconstruct many of these complex aneurysms, like this complex shaped anterior communicating aneurysm, again using the tandem clipping technique in this case to provide a durable treatment. Moving on, thrombotic aneurysms are aneurysms that are notoriously resistant to endovascular therapy. When they are treated with coiling, oftentimes the coil will migrate into the aneurysm within a short period of time. And even with flow diversion, oftentimes the mass effect from the thrombosis remains, and removing the thrombus surgically can be helpful. This is a patient with a large thrombosed aneurysm that's causing obviously visual loss. It's, you can see the huge thrombotic component of it. The angiogram, you can see that a very small portion of the aneurysm is filling angiographically. So even though it's ugly on the MRI, the surgical treatment of this is very straightforward. This is on the left side. You can see the neck of the aneurysm there. We do an ICG, which illustrates the neck, and a simple side-angled clip placed across the neck of the aneurysm so that it's parallel with the axis of the carotid artery, easily eliminates the aneurysm from the circulation. And in this case, I don't like using retractors, but in this case, I use a retractor just gently to protect the frontal lobe while we open the aneurysm, decompress the optic chiasm and optic nerve using an ultrasonic aspirator to aspirate the thrombotic contents. This aneurysm is massive. It was several centimeters in size. We're not going to attempt to remove every bit of it, but I want to get the trapped blood out, and I want to get some of the thrombus out so that we can provide immediate and rapid decompression of the optic apparatus. The rest of it will involute over time, and you can see that with the aneurysm clipped, using a combination of ultrasonic aspiration and pituitary rongeurs, we can decompress the optic apparatus and in a much more immediate and durable way than endovascular therapy would provide. You can see the reconstructed carotid, the lax aneurysm, and the intraoperative angiogram and postoperative CT. Moving on, I think one of the growing indications for aneurysm surgery in the 21st century are endovascular failures. This is a 36-year-old man who had presented in Tennessee to a hospital in 2015 with this large aneurysm arising at the carotid bifurcation M1 segment, and had undergone endovascular therapy with coiling. He was lost to follow-up and presented to us 5 years later, this past year, with a massive enlargement of his aneurysm, a new hemorrhage, much of it into the aneurysm itself. And you can now see the coil mass. You can see his temporal arteries. And on this angiogram, I've outlined the mass effect of the aneurysm, but you can see just a little portion of it is filling, and there is a high-grade stenosis right before the lenticulostriates. So our plan for this, we didn't really think there was a good endovascular option with that very high-grade stenosis. The plan was, as you see on the 3D angiogram, to do a radial artery bypass here, and then put a clip distal to the aneurysm, but proximal to the lenticulostriates, to create a blind sac. Here's the angiogram after surgery showing the radial artery graft filling the middle cerebral artery nicely. Here you can see the AP, and you can see the arrows point to the lenticulostriates, which are filling retrograde up to the clip, and the blind sac you can see is now gone. And the entire aneurysm is thrombosed, and the patient had no neurological deficits whatsoever with this treatment. And I really don't think there would have been a good endovascular treatment for that would have provided this type of result. Fusiform and blister aneurysms are difficult to treat by either endovascular or surgical means. And there are endovascular options. They generally require dual antiplatelet therapy, which we generally try to avoid, particularly in patients with recent subarachnoid hemorrhage. So I just want to remind people that there are surgical options for these. This is a patient with a blister aneurysm who has this pathology. These things are treacherous. And at the time of surgery, the artery literally can fall apart. But one of the tricks for these, and I give credit again to my dear friend and mentor, Robert Spetzler. Robert really introduced me to this technique through conversations we had. But in this procedure, you can see on the right side, we're dissecting in front of the blister, trying to avoid where the blister is, and just making an opening through which I can pass a piece of Gore-Tex that we will put around the carotid artery from lateral to medial. You can see the posterior communicating artery. One of the benefits of Gore-Tex is you can actually cut a slit in it to accommodate the anterior choroidal, the posterior communicator. We didn't need to do that in this case, but that's one of the benefits. So we're now grasping it on the other side, and it's coming around where the blister is. And so it's now being used kind of like a diaper. You can see the blister. Fortunately, it didn't bleed. But using now a small right-angled aneurysm clip, we can clip the Gore-Tex to the carotid. And the goal is to barely narrow the lumen of the carotid artery so that it can heal itself. I show this case, and I picked this one in particular because I want to show a mistake I made. We used ICG, and you see the ICG shows the posterior communicating and the carotid filling fine. But ICG is not quantitative. And so we always, when we do these, use intraoperative angiography, because even though the ICG looked good, on the intraoperative angiogram, you can see that I've narrowed the carotid too much, and there's delayed filling of the middle cerebral artery. Not enough that the ICG didn't fill, but enough that it probably would have caused ischemia. Seeing this intraoperatively, I immediately go back, and I literally just move the clip about 2 millimeters to increase the lumen of the carotid, repeat the intraoperative angiogram, and you can see a beautiful reconstruction of that, which went on to heal. He subsequently has had a multi-year follow-up angiogram, and this is completely healed. Fusiform aneurysms. This is a young boy from Africa that had a hemorrhage from this aneurysm. You can see on the 3D, it's just a big fusiform aneurysm of the distal middle cerebral artery. The plan here was very simply to do a temporal artery bypass here distally and trap the aneurysm at those two places. The intraoperative angiogram, you can see there's a hole in the cerebral vasculature right here, but when we inject the external carotid, you can see that the bypass fills that. It's a very nice way in a young boy to fix this on a permanent basis. Fortunately, that segment had no branches, and so it could be sacrificed with impunity after revascularizing the single branch that came out of it. Here's another fusiform aneurysm. This is a patient presented with seizures from mass effect from this middle cerebral aneurysm. And unlike the endovascular failure I showed earlier, where we created a blind sac, the strategy here was a little different. We did a radial artery graft here, but rather than creating a blind sac, we actually occluded it proximally to reverse flow in the aneurysm because I was concerned about lenticulostriates. And what that did is, here's the intraoperative angiogram showing the proximal bypass, and you can see that it's filling retrograde intraoperatively. And this is the long-term follow-up angiogram showing the radial artery bypass. You can see it filling retrograde, but the aneurysm completely occluded and over time, and you can see before and after the thrombosis and shrinkage of the aneurysm. So just another strategy to get rid of a fusiform aneurysm. I just want to remind you that endovascular options and surgical options are not mutually exclusive. In fact, they can sometimes be complementary. This is a young man in his late 20s who had this fusiform middle cerebral aneurysm, but notice he has a middle cerebral artery branch coming right out of the dome of the aneurysm. This is probably some kind of a dissection, and I really didn't feel that I would be able to adequately reconstruct this with clips. So we decided to do a bypass to that branch occlude it proximally, and then treat the aneurysm with flow diversion. So at the time of surgery, one of the challenges was which branch of the middle cerebral artery is that one coming out of the aneurysm. And so one of the tricks to identify that is to do an ICG run with a temporary clip on the artery coming out of the aneurysm after opening the sylvian fissure. The ICG, you can see that there is the inferior branch fills. You can see there's a dark spot. When I take the temporary clip off, it fills, and that's the branch that we bypass to. Now, here's the postoperative angiogram at the time of treatment. You can see the aneurysm clip occluding the branch coming out of the dome. You can see the flow diverter in place, and almost immediately the aneurysm is thrombosing, and the external carotid shows the bypass fills that branch that came out of the aneurysm. Multiple aneurysms are another. This is a woman from South America in her home country. They recommended that she undergo endovascular therapy for her basilar tip aneurysm and surgical treatment of her middle cerebral artery aneurysm. That again is just completely illogical. At the time of surgery, I won't show the basilar tip, but you can see the clip. We've already clipped the basilar tip aneurysm. It's literally an inch away from the middle cerebral aneurysm. And this middle cerebral aneurysm really doesn't have a good endovascular option. And so under direct vision through an open sylvian fissure, we use, in this case, what Ralph Dacey has referred to as the shank clip to get this somewhat oblong aneurysm obliterated. And I show this case both to demonstrate that both of those aneurysms should be treated surgically, not two separate procedures, but also to show that even with direct observation and ICG, which shows that the aneurysm is gone, the middle cerebral branches fill well, under very close inspection, you can see there's a little dog ear that is left. And this is the beauty of surgery, is that we can make that perfect. Just take a fenestrated clip and occlude that little dog ear that might potentially be the source of a recurrence in the future. And both aneurysms fixed. This is a patient who had a ruptured left middle cerebral artery aneurysm, the large one on the left, but has a small middle cerebral aneurysm on the right. At the time of surgery, the aneurysm ruptures. I don't like to use fixed retractors, but I always have one ready. And here's an example why. In this case, I put a piece of cotton over the bleeding site, and I'm using the retractor as a third arm to tamponade the aneurysm for me. I'm now opening the lamina terminalis, and that retractor now has served its purpose. The bleeding has stopped. I've got a nice relaxed brain. There's the ruptured aneurysm. It's a complex configuration. A temporary clip is put on to soften the aneurysm, and a series of clips are used to reconstruct this very complex configured aneurysm, the source of the subarachnoid hemorrhage, after the intraoperative hemorrhage was controlled with the retractor serving as a third arm, if you will. ICG shows that everything's fine, but now with a relaxed brain, I can look across the chiasm into the contralateral sylvian fissure, and there's the unruptured middle cerebral aneurysm. It's a short M1, so it's a very simple matter to reach across and clip that aneurysm, the unruptured one, and eliminate the need for a future operation down the road or a future endovascular therapy. Infectious aneurysms, I think, are another area where surgery needs to be considered. This is a patient with an infectious aneurysm on the a duplicate middle cerebral artery that during antibiotic therapy did this. And so we just simply went in and used the anterior superficial temporal artery branch, trapped the aneurysm, and did a bypass to the distal branch and got rid of the infectious aneurysm without putting something inside an infected aneurysm. And finally, I would say that I'm very concerned about endovascular therapy in the very young. This is a 9-year-old that had mass effect from this aneurysm involving the cavernous segment of his carotid. Putting a flow diverter into a 9-year-old, I don't know what that's going to do. So our choice was to use a saphenous vein graft, as you can see here in the postoperative CTA, to reconstruct his carotid artery and trap the cavernous aneurysm. And I still think for youngsters, this may be an option. I'm going to move on at this point. I just want to end by saying that surgery is not minimally invasive, but it should be minimally disruptive. We should leave no traces that we were there. And I think if we pay attention to our technique, if we continue to train the next generation of neurosurgeons to do microsurgery, I think there will be, for the foreseeable future, a role for microsurgery in the treatment of vascular lesions. But it's only if we make sure that the field does not become dormant, the field continues to improve, and that we teach that next generation. And going back to what I said in the beginning, I do think it will involve a certain portion of our faculty having a bit of a surgical bias, an appropriate surgical bias, but a bias nonetheless. So I'm going to stop at that point, and thank you again for the invitation.
Thanks, Dan, very much. Would you mind unshare your screen, and then Robert could share his, and we'll have questions in the discussion period.
Okay. Let me see. Okay, here, stop.
I unshared it for him.
Thank you.
Do you see it, Jacques?
Yes, yes.
You see the full screen?
Not full. We have a double slide, thing. We see the next slide and the current slide.
And we want to bring. Okay. Can you hear me?
Yes, now it's perfect. Yes, we hear you.
Well, thank you, Jacques, for the invitation. I think we just heard a terrific lecture from Dan. Dan's eloquence has always surpassed mine, and he said so many things I wanted to say. I can make this really shorter. So here's.
Believe that when we hear it.
You should be on mute, Dan. Please turn yourself on to mute. And he really nicely elucidated the clipping and the coiling controversy. I think what is the justification? Well, there is no trial that specifically compares posterior fossa aneurysms with different treatments. Except for Brad, every other trial has avoided posterior fossa aneurysms, and in fact, in ISAT, they mentioned that patients with ruptured posterior circulation aneurysms, and to a lesser extent, middle cerebral aneurysms, and those in poor clinical grade are underrepresented in the ISAT cohort. In Brad, it was prospective, it was randomized, there were no anatomic exclusion, it was an intent to treat, and all patients were entered within the first 24 hours. It is important to remember that there were 36% crossovers from those randomized to coiling that actually ended up being clipped. And that means more than a third of the patients that were evaluated for embolization, for coiling, were felt not to be appropriate for that treatment. There was no difference, as Dan already mentioned, in the modified Rankin score greater than 2 at any time up to 10 years. However, retreatment, subsequent subarachnoid, and death favored clipping. So in my mind, microsurgery remains the gold standard for permanent obliteration and protection from further subarachnoid hemorrhages. I remind you that 362 were assigned, 356 were treated, 6 died prior to treatment, 3 in each group. And if you recall in ISAT, which I won't spend much time on, but there were a lot more death, 14 more death in those assigned to surgery because there was a delay in treatment of 14 hours compared to coiling. Crossover, 36%. Only one of those assigned to clip was crossed over to coiling. So 68% of those actually of the patients in that cohort were clipped, 32% were coiled. Unfortunately for the posterior fossa, there was very poor anatomic parity between the various sites. So superior cerebellar artery, all were clipped, PCA, all were coiled or assigned to coiling. And naturally, there was a huge, again, number of patients, 36% that were crossed over to clipping. So even though the modified Rankin score is no different at 10 years, and that's not unreasonable because you have to think of cardiac disease, cancer, et cetera, all take their toll and really are bigger factors in determining longevity. But we're treating only aneurysms. So for retreatments at 10 years, 19% of the patients that were assigned to coiling required retreatment. Less than 1% of those assigned to clipping. As far as actual obliteration, independently adjudicated by a neuroradiologist, 93% of those that were clipped had complete obliteration of their aneurysm. Only 22% of those treated by endovascular means were obliterated. Most importantly, naturally, is the whole purpose of our treatment is to prevent rebleeds. In the follow-up at 10 years, there were 2 subarachnoid hemorrhages out of the 83 patients available at 10 years. There were 0 in the 175 that were clipped, which reached significance. Here's one that had recurred, that was a basilar artery aneurysm, nicely coiled, but obviously recurrence and death. The critical question remains, how effective is the treatment? And we see these cases over and over again. Dan just showed some beautiful ones. Recurrence, twice coiled, recurrence, recurrence, and naturally at some point in time, the patient is absolutely devastated. Incomplete treatment risks, as I mentioned for Brad, is subarachnoid hemorrhage. It's further aneurysm grows. And so for aneurysm regrowth after incomplete obliteration, it doesn't make any difference whether it's coiling or clipping. Here's one that was clipped. 8 years later, you can see the recurrence. However, if you consider that in the coiled cohort, 78% of patients had an incompletely obliterated aneurysm, that risk of recurrence of an aneurysm has to be significant. We also don't talk about other symptoms. This is coil migration. This is coils that have migrated in the optic nerve and caused optic deficit 8 years after coiling. This is a neuro-ophthalmologist with the PCOM aneurysm where the coils meandered into the third nerve, causing a third nerve deficit. Obviously, microsurgery for posterior fossa aneurysms is selection, and it's all perforators. I'm very high on not using retractors except when you need them, and you have these other modalities that you could use if necessary. For the posterior fossa, there are really 3 basic approaches: the OZ, the retrosic, and the far lateral. I also include this one off to the side because I'm going to show you a case, but it's really very rare aneurysm. But for the OZ, obviously the exposure with the OZ, you just get a little more room, requiring less retraction, getting you right down.
Robert,
Yes.
may I interrupt you a little bit? Your voice is being crackling. I'm not sure if you need to get closer to your microphone. It's on and off a little bit. Maybe.
Is this better?
I think so, yes.
Okay, we'll try that. So microsurgery is very feasible. This is a 50-year-old female. She had presented with headache and a subarachnoid hemorrhage. You can see it right here. here's the external control retractors in place, basilar arteries, superior arteries on both sides. Posterior cerebral artery getting those perforators on the ipsilateral side, and on the contralateral side. It is key that you have to be 100% sure that you have not trapped a thalamo perforator. Is it still bad?
Robert, I'm sorry to interrupt you again. We're still having problems. Do you think you can lower your volume? Let's try it a little bit lower, perhaps. It's kind of crackling and becomes ununderstandable.
Okay. How's that?
Yeah, now, yeah, when you say that, then it's intermittent for some reason. Try it. Let's keep going.
Okay. Yeah. All right. Can you hear me now fine?
Yes.
Okay. So flow diversion works, and it's nothing new. And if you go back in the literature, May 1961, Lester Mound and Juan Taveras reported the occlusion of the basilar artery below a large aneurysm, which worked very nicely. And so when you have these recurrences, this is a 48-year-old female, did not present with a subarachnoid hemorrhage, has recurrence of her aneurysm, had a good Alcock test because good posterior communicating arteries. When I see a case like this is through the OT, I will always first see if we can clip it right. This is what happens when you try to clip it correctly. So we're going right down and put a clip across the basilar artery.
Robert, I'm sorry to interrupt you. It only happens when you play a video for some reason. The video interferes with your voice. I'm not sure why. I would have thought the opposite, but that's what's happening. Maybe you can let the video play and then make your comments after the video. We could try that.
Okay. Is it better now when I turn that off or not?
Yeah. Yeah, now is okay. Yeah, now I hear you.
Okay.
Yes.
I think I see the problem. So here, occluding the basilar artery just below the superior cerebellar arteries. So if you look at the left injection, you see the PCOM, you see the posterior cerebral artery and the SCA. Same thing on the right side, PCOM, posterior cerebral artery and SCA, and from below this. And this really works well in those where you have good PCOMs. And when you don't have a good PCOM, then you obviously have to add on a bypass like an STA, SCA. So just one more example here is we have a recurrent basilar artery aneurysm, as we've all seen so many. Okay. And is my voice okay now?
Yes.
Yeah. So this is thalamoperforator on the left side. Everything depends naturally on getting the thalamoperforators out. This is the fenestrated clip, very similar to what Dan showed. My only goal is to get the distal portion of the neck and then put a clip to shut off the fenestration. And we see nice filling. And that's what it looks like post-op. One more case like this, 47-year-old with this large recurrence of an aneurysm after coiling, was repeated 3 times. Alcock test was not good, but we're looking at it again before we decide whether to do a bypass and occluding the basilar artery. So fenestrated clip, superior cerebellar arteries, posterior cerebral arteries. This clip incorporates the posterior cerebral artery on the right side. It looks like it's tight here, posterior cerebral artery there. So we put a fenestrated clip behind the one that we replaced. Remove the first one now providing adequate visualization of the PCOM on that side, and the posterior cerebral is in the fenestration, but the extra clip is behind the posterior cerebral artery, and this is our result. Basilar artery aneurysms are by far the most common of the aneurysms in the posterior fossa, and we should feel very comfortable in treating them. I like the OC approach. When I was young, we started with the temporal and a half path. The advantage of the OC is that you can see both sides of people better than from any other view. So if you're mobilizing the vascular artery, no retractors in place, the curved foot goes around the base. You're concentrating completely on preserving the perforators. Post-op, and she went home on the second post-operative day. We need to remember that the posterior, the SCA aneurysms are really the easiest because they are free of perforators and they are exposed and they're lateral, and so you really get there very easily. Again, we come to the Sylvian picture. One of the points I emphasize is that if you follow the anterior choroidal artery, you will open up the space beautifully. And then once you're done, you leave the arachnoid attached to the third nerve so that it pulls it away. And then you're the artery.
Robert, you're clacking again. Maybe if you try skipping through the video, it's a bandwidth issue, I think. Your computer somehow is not able to carry both the video and your voice. Or
Dan did that.
Well, or your endovascular colleagues, maybe.
Is the video playing well?
Yeah, I mean, it's a bit choppy, but once you speak, your voice crackles as if it's a bandwidth limit in your Wi-Fi.
Well, here you can see the aneurysm gone nicely, and that really is an easy one. So the question is, when you have somebody with a subarachnoid hemorrhage like this, and you have a perfectly normal scan, you repeat an angiogram in a year, or an MRI, a CTA, or before discharge. So we're going to repeat it before discharge. And now we see the emergence of the blister aneurysm 9 days later. And we know that they are particularly dangerous. So I'm not going to talk, I'm just going to let the video play. PCOM. Here you see the aneurysm. And gone. retrosig. Aneurysm. Sixth nerve. Aneurysm embedded in the brainstem. Creating room for the tine. And aneurysm gone. The point is really that we could do a great deal through the retrosigmoid approach. Far lateral. Paramedian incision. Paramedian means you can do a very short, small opening. This is a 71-year-old coiled 3 times. You can see it. You can see recurrence. This is pica coming out of the aneurysm. Those are the coils. Temporary clip on the vertebral artery and distal on the vertebral artery. Trying to clip the aneurysm. That's pica. Unfortunately, it tore off the vertebral artery. Hold the vertebral pica. Hooking the vertebral to the pica. So here you can see vertebral artery, and the pica has been re-implanted into the vertebral artery where the aneurysm and pica originally extended. And that's pre-op. And here you can see the bypass very nicely filling. And everything's intact. And finally, superior supracerebellar infratemporal. This approach, this has gotten larger. Contortion. And the ancestor. So really all basically just to, oh, I better stop this here. Basically to avoid clipping any of those little vessels. So I think retractorless aneurysm surgery is feasible and safe even for posterior fossa aneurysms. Safe approaches are readily available for all posterior fossa aneurysms, and they are amenable to microsurgical treatment. I thank you for your attention.
Thanks, Robert. Thank you very much. Sorry about the technical problem with the sound. It's clearly a bandwidth issue. Could you unshare your screen? And now we are going to have our 4 panelists in that following order: Dr. Paul Camarata, and then Carlos David, Anthony Wang, Stacy Wolfe. Show 1 case each to our speakers and to engage them into a conversation. And after that, we will answer the many questions that have arrived in the Q&A. We've just so to let you know, we have about 650 participants or so a few minutes ago. Go ahead, Paul, please.
Okay.
If you could share your screen.
Thanks so much, Jacques. It's an honor to be here. It's an incredible thing you're doing, sharing this with literally 700 people all over the country. It's like we've had 2 keynotes from masters in cerebrovascular surgery for free this afternoon. So yeah, I'll try and share my screen. I have an interesting case. And let me just go back to the beginning of it here to see what the panel would say. Let's see. Okay, I have to go out of my full screen and share. Okay. So are you seeing my screen now? Just the PowerPoint?
Yes.
Okay.
Yes.
This was a 39-year-old woman that we got asked to see by the vascular surgeons. She had a 2-week history of right neck fullness, which was interpreted to be lymphadenopathy, little trouble swallowing, and she actually had trouble breathing one day. She had a hoarse voice over the last week. Interestingly, 22 years ago, she had had a sudden neck pain, weakness, and residual hemiparesis from a vertebral dissecting aneurysm that completely thrombosed. She was actually seen in Phoenix, and it was too late by the time she got there to do anything about it. She lived 22 years very, very normally. I mean, walked with a mild hemiparesis, but and a lower cranial nerve deficit on the right side. So this time she comes in, her exam is similar, left hemiparesis. She walks without assistance. She has this old left vocal cord issue from a previous stroke. But she got admitted to the vascular surgery service, and this is what they found. This is a CTA. And I call your attention to the right side of the neck here, where there's a very large lesion, partially thrombosed, that literally goes all the way to the skull base. The arteriogram, this is a common injection here, just showing kind of what that looks like. And I'll show you the rest of the arteriogram for completeness sake. This is a right ICA lateral and an AP. And all right, stop that. And this is an external on the right side, reasonable STAs. This is the vertebral injections. This is the right, which is the place where she had this dissecting aneurysm years ago, and it just dead ends. And the left vert, which ends in a pica. She's got some dysplastic connection with her occipital artery there. And her left carotid, I actually got to stop all these videos in order to advance the slide here. Her left carotid actually looks normal, other than this tortuosity in the neck. Any thoughts And an interesting finding here, which I think was undoubtedly present, helped her when she had her thrombosis 22 years ago.
Dan, do you want to give your opinion on this? Make sure you're not muted.
Okay, I think I'm unmuted now.
Yeah.
Yeah, I mean, one option, if I got that all correct, I think would be to sacrifice the diseased carotid and replace it with a high flow bypass. I think the temporal arteries, the temporal arteries were good, but I probably wouldn't trust a temporal artery for that. I think the segment of it is so long that I don't think there's a good endovascular option, but I would have to defer to somebody who does endovascular therapy. But that's a long segment to try to reconstruct by endovascular means. So I think the surgical option would be to sacrifice the carotid with a replacement.
Well, we actually have Bobby Stark. Bobby, can you hear me? Bobby, my partner who does endovascular. I don't know if you saw the whole case, Bobby. Is there an endovascular option for this meandering carotid, in your opinion?
Yeah, I think probably an open microsurgical approach would be pretty reasonable. If we were going to do an endovascular approach, I think it's certainly possible. This kink down here below would make the case a little bit more challenging, and we'd have to measure the size of the segment here. But we could reconstruct this with multiple flow diverting stents would be another option. I would probably want to do a balloon occlusion test first to see, does she really need that vessel?
Okay, that's a good point. We did do a BTO, and she, let's see if I've got that here next, I think. This is the BTO. So this is a BTO. She tolerated it fine, and under hypotension. Did get a SPECT as well, which maybe shows a little bit down on the right side.
Paul, do you do a hypotensive challenge in
Yes.
BTO?
Yes, yeah, she had a hypotensive challenge and did fine. Now, she's 39, has no verts and one normal carotid, if you take this down.
Yeah, I don't think the balloon test occlusion really is going to change anything that I would do. But one of the things that I do whenever I see a case like this, and I do want to share it with everybody, is I go to this and I say, Robert, what would you do? Robert tells me exactly what he would do, and I take his advice always.
Well, we now have him live, so let's see what he says. Robert, unmute yourself and hope if, yeah, let's see if you're going to crack
Yeah, I think this is a great case. I think the first thing we need to remember is that there was a vertebral artery dissection which greatly compromised the flow to the posterior fossa. She then had a dissection of the carotid artery, which is now one of two remaining vessels. So she is somebody that is at much higher risk of further dissections than somebody that's never had a dissection. So I am impressed with the SPECT scan and the BTO, but we know that they're not very predictive as to tolerance. However, because an STA MCA can really grow into a vessel that can be that can grow and be significant in the amount of blood supply, I'd be tempted to offer her a low risk, low flow bypass because of what the balloon occlusion test showed, and let it grow as it demands further flow.
So, Paul, what did you do? Or you haven't done it yet?
Yeah, no, we did it. Let's see. I can, I'm going to, let's see, stop sharing just so I can, let's see. Well, I can't. Oh, here we go. Stop share so I can get the video up, but I won't do. Are you seeing any video here?
It's coming.
Yeah. Okay. So we did a high flow bypass. We used a radial artery, and we did contemplate the STA. I was concerned that with less flow in the SCA, and I understand it could increase with time, but that she might, for a significant period of time, have more stress on that left side. And she's obviously got some vascular disease, some collagen disease, and the fact that she's lost now 3 of her major arteries. I thought this was the way to go. This is the neck and the vessel coming in down here. I can speed through this so we can get to the other videos. I'll just go to the end here. And this is the neck. Actually, the vascular surgeons wanted to do the anastomosis here. This is the aneurysm here. You see how the hypoglossal's been pushed way forward. And they went in and connected the radial artery graft to the ICA, right distal to the bifurcation, and did a really nice job. But she did well, has survived now a couple of years afterwards, and the vessel is actually hypertrophied, and you can see so here's the immediate post-op. The carotid was sacrificed very high in the neck and oversewn, and then it has thrombosed in the interim. And I just wanted to briefly show this last picture. This is the 2-year CTA, and you can see all the mass effect in the neck has essentially gone. And the other interesting thing is that the M1 and A1 have become attenuated on that side. You can see there. There's actually a better demonstration of it on the next slide, where you see here is the pre-CTA, and here is the CTA now with the intact bypass.
Nice job.
We haven't figured out what she has. She has some mutation on I can't even remember the name of the gene right now, but it's concerned with collagen vascular disease.
Thanks, Paul. Any final comments from our speakers on the case?
I think perfectly reasonable approach and solution to the problem, but she has a lot of years ahead of her.
Great, thanks. Carlos David, why don't you share your screen? And you're muted.
Yes, can you hear me now?
Yes.
All right. Get started. Okay. See my slides?
Yes.
Okay, perfect. So this is a case that's apropos of Dr. Barrow and Dr. Spetzler's talks a few moments ago. I hope we can get some of the endovascular opinions as we go along. But I like to title it "One Bad Turn Begets Another and Another and Another." So let me take you way back, a long time ago, in an operating room far, far away. And these are the guys that I tried to distill every skill out of as I faced the world and thought, okay, all the aneurysms are there for the taking. Unfortunately, this stuff came. And you all know this graph, but I've kind of personalized it because I graduated in 1996, and you can see what happened to the volume throughout my career. And you can also see my emotional state as it went throughout the career. So the state of my current practice is basically the sloppy leftovers, and let me share one with you. So this is now 2004, 51-year-old woman presents with a 3-week history of severe headaches. They were not sudden, or they were sudden, they were associated with nausea, but her CT and LP were negative for subarachnoid hemorrhage. But an aneurysm was identified. Now, it's so far back that we don't have the original films, but I have one that looks relatively similar to what it looked like at that time. So the question is, what would you do in 2004, and what would we do today with that aneurysm? Do you want me to keep going, or do you want to add some discussion at this point?
Dan, what would you do with this case?
In
Are you mute?
2004, I would have operated on it without really much discussion. Today, I mean, as with most of our patients, we have a very open, honest discussion about the options. And with an unruptured aneurysm, I would ask an endovascular colleague to give an unbiased opinion as to what they could offer. And at 51 years of age, I think this is an aneurysm for which there is that equipoise that I was talking about. I think there are two reasonable options, and I would let the patient be involved in decision making.
So that's basically what we did. It was, she saw me at that time, and she saw INSUP Choi at that time, and she really didn't want her head opened. So they went ahead and coiled it. And we don't have the initial results. Those are gone in ARC well, but I have the 6-month follow-up angio, and it looks like a reasonably good result. But then at the 1-year follow-up, we have this. And at this point, I wasn't part of her care any longer, so I would assume most endovascular folks out there would say, go ahead and recoil it. I'm wondering, would you clip it at this point or continue the course?
Carlos, let me ask Robert a question. Robert, just tell us your general approach on clippability of a previously coiled aneurysm. When you look at a recanalized coiled aneurysm, what do you look at geometrically to decide clippability?
Yeah, you know what, once it's coiled, naturally, it's much more difficult. So I think the real question is, how much room is there between the coil mass and the base of the aneurysm? And can you geometrically bring the base together without compromising the feeding vessels? My impression on this case to start off with is this is no different than a basilar artery aneurysm. The internal carotid artery shoots directly into the aneurysm. So just putting in coils predictably is going to cause a recurrence. If you can put some sort of flow diverter from the internal to the middle cerebral artery, that would make more sense to me. But just coils for this aneurysm is predictably going to fail. So now you are going to either have to add on a flow diverter and stents, which I think is reasonable, or you're going to have to consider open surgery.
So this was 2005, and what they did was more coiling. So they recoil, and then the follow-up angio in 2008, you can see it there on the right, and you're starting to see recurrence again. And not to belabor this, again, she never saw a surgeon at that point. They decided to just watch it, and they did x-rays every few years to kind of keep an eye on the mass. And it gradually changed, and finally someone got an MRI, and now you have that, which led to the 2018 angiogram, which appears like this. So there's been a significant recurrence. So again, the option of clipping versus more coiling, well, she decided to seek an opinion at another hospital. A new angiogram was obtained, and endovascular treatment was recommended, precisely what Dr. Spetzler just mentioned, flow diversion. So a pipeline was placed from the ICA, quite proximally actually, all the way out to the MCA, crossing and basically blocking off the A1. And you can see here how the pipeline device is coming and then looping towards us in this location here.
Carlos, let me interrupt you to ask Bobby Stark. Bobby, any comment on the placement of this pipeline? Is this how you would do it if you had to do it?
Yeah, I agree with Dr. Spetzler in that this isn't really a great case for a pipeline, and probably part of the neck goes close to the A1 segment. So in a younger person with the ICA terminus aneurysm pointing up like this or anteriorly, I probably would have favored clipping. We had a patient recently with a history of thrombosis and a thrombosed fistula with the same aneurysm. And I went from a right radial approach across the ACOM and placed a stent from the A1 to the M1. this alone, I think, is not going to lead to obliteration of this aneurysm because you haven't reconstructed the base of the aneurysm fully.
Okay, Carlos, what did you do?
So let me just jump in here. I sense where this is going, and I'm thinking that how are you going to put a temporary clip on the pipeline?
Well, no, it's not quite there yet. So she has this procedure done, and on the follow-up angiogram, it's growing, and she's now developed this stenotic area of irregularities in the vessel. The surgeon who treated her wanted to put a second pipeline device across here. And I just want to show this. You can really see the rattiness of the vessel. She was on dual antiplatelets at that time. She now came to see my endovascular colleague, who basically punted, said, I have no access. He did not feel comfortable putting a second pipeline in, and there was no way to cross over to come in from the A1 from the other side, and essentially I had no access through the stent. So now she comes back to see me 15 years later with that. So, you know, the factors to consider, what went through my mind was that stenosis. I was worried about that. So I left her on dual antiplatelets for a few months in hopes that that would ease up, and repeated the angiogram at 3 months. And now on the follow-up angiogram, you can see here, there's sluggish flow in that A1. The stenosis has improved significantly. And at this point now, I'm ready to take her to surgery. So considerations, I don't know if you want to open this up to the panel, but I can give you my thoughts.
No, it's okay. Go ahead, Carlos. Tell us what you did.
My thoughts on this case were, let me just go ahead and start the video. I didn't have proximal control because the pipeline went too far towards the skull base. So we opened the neck. I did a frontal orbital just in case I needed more rooms. I wasn't sure I was going to be able to get in front of this aneurysm. And to protect myself, I went ahead and did a bypass as well, just kind of to protect myself from that. So splitting the fissure, when we get down, you'll see now the times of the pipeline. It's a pretty dramatic view. Let me just speed it up a little bit.
Carlos,
Yeah.
why are you operating?
Why am I operating?
It looks to be like you've cured the aneurysm. You've done what I would have suggested last time around. If you looked at your angiogram, what you really needed to do is you needed to stop the flow in the A1. A very simple procedure. You could do ipsilateral or contralateral, but that's already happened now by itself.
Right, but the aneurysm was still filling.
But just barely. Totally different than before. And by the way, I've put many a clip across pipelines, and they tolerated well, and they jump right back open after you take the clip off.
No, we had the concern that it wasn't going to thrombose off. Dr. Waklu felt that, you know, it wasn't going to work. And I felt at that point, for so many recurrences, that there was still flow. The stenosis had improved to go ahead and just operate. So I put in a bypass just to protect myself, went down to the actual aneurysm, clamping the carotid in the neck, and it still was such a hard mass, you couldn't get clips on it. So just to speed this up, I had to open it, put a couple clips on, open it up, because it was still flowing, just to remove enough debris to make room for another clip. I'll get to the ICG. I put the final clip on. And then the ICG, you can see the stent there all the way. Everything's filling. And then the post-op. So.
It's a nice case, Carlos, but can you go back to that last angiogram before surgery? Because what your surgery really did was shut off the rest of that little anterior cerebral artery. I mean, A1. You see that little, you just had a tiny little A1 left in July of 19. I mean, nice case, but a big operation, which you might have been able to avoid.
You're saying
There
this,
ACOM there?
Yeah, I think this little, if you look at the middle internal carotid artery, it's going right to the middle cerebral artery. And then there's a little branch coming off, which I think is the residual A1, because that's where the aneurysm comes off. It's just from the residual A1 that it's coming off of. And that all it required was occlusion of that A1 distal to the aneurysm on the previous angiogram. Does that make any sense to you? If you go back to your earlier angiograms, Carlos, what happened is that the flow, there was dramatic flow on the anterior cerebral artery to the anterior cerebral artery distribution. What you needed to do, get rid of, right at this point of the angiogram, all you had to do was occlude A1 right next to the aneurysm.
similar to like a fetal PCOM
Yeah,
concept,
yeah,
as long as
exactly.
it's needed. Yeah.
Yeah, you're getting rid of that flow. Obviously, you needed a balloon occlusion test to make sure that you're at cross-filling, but in the final analysis, you've proven it because now the A1 is completely gone after the surgery.
Right.
Neat case.
Thank Carlos. May I have Anthony Wang? Could you unshare your screen, Carlos? And then Anthony Wang from UCLA, who does cerebrovascular and pediatric and skull base. Welcome, Anthony, and show us what
Good to
you've
be
got.
here. Thank you. While I pull up my screen, I just had a quick question that I was hoping Bobby might answer about the prior case. Like these days, would there be a role for something like a pulse rider device at any stage in the treatment of that aneurysm?
Yeah, I think a pulse rider would be a reasonable option. You would have a T, and then you could buttress that with coils. Another option that we've done in a number of cases is come across the ACOM so that you put a stent from the M1 to the A1, and then you have a really nice buttress for coils. I think there's probably some places that would have considered a web, earlier on if it wasn't so large. I mean, I think all those are reasonable options. I think clipping would have been a reasonable option as well. And then when the aneurysm came back, I think he presented a really nice bypass. Another option aside from just clipping the A1 would have been just to come across the ACOM and coil the inflow of the aneurysm and the proximal part of the A1. And that may have done it.
That was the issue. They couldn't come. There was no ACOM to come across. I'd shown that on a previous image, but there was no ACOM that you could get across, and so that whole A1 segment was basically jailed by itself.
Dr. Morcos, is this the correct screen that I'm showing now?
Yes.
Okay, great. So, yeah, just kind of fortuitously, I have this panel of experts that I can run this by because I need a little bit of advice, and I try to kind of made a habit of doing this, of asking for advice from you guys, Dr. Spetzler, Dr. Barrow, Dr. Morcos, whenever I have the opportunity. This is a 10-year-old girl who was referred to me in clinic last week. But when I actually saw her dad said, "Oh, by the way, she had a really bad headache yesterday, and she lost the rest of her vision in her right eye." And so these are the MRI images that she came to me with. And so, you can kind of predict what the angiogram is going to show. It takes a little bit of, it took a little bit of guessing, but, the ophthalmic is clearly coming out of this aneurysm. It looks like it just barely involves the posterior communicating artery. And here is, on the left here, it's not an ICA injection. That's just showing the PCOM. And then this one on the right is just the left ICA. We did, I guess the interventionalist did do an Alcock test, and there was not, and the filling kind of didn't really increase a lot across the ACOM. This is just one of the reconstructions, but this right here, just because you can't see it very well, would be the start of the landing zone for a flow diverting stent. And then just for completeness sake, here's the STA on her with a really high bifurcation. And so I wanted to stop here and bring up a couple of discussion points to ask our panelists. First of all, what are our options for treatment? Second of all, what are our goals for surgery? And then kind of particular surgical considerations that you'd want to know before we make a decision or that might inform the treatment that you offer.
Can we ask what Stacy? Did you looked at the case? Maybe we can start with Stacy. If you unmute yourself, Stacy.
Fair enough. So, obviously a difficult case. As far as looking at this from an endovascular standpoint, I think that Dr. Barrow and Dr. Spetzler pointed out appropriately. We don't know exactly what flow diversion does in these younger kids. There are certainly case series even down to 9 months old where flow diverters have been used and successfully so, but as far as very long-term follow-up, we don't have that well yet. And so I think that's always an important consideration, certainly when speaking with the families about what to do. And so, in these younger folks, certainly considering, bypass with reconstruction, I think is something that needs to be really well considered. This kid is old enough that we don't have to worry about major blood loss and that kind of thing.
Dan?
Yeah. Well, the goal of surgery, that's the easy question. And the goal of surgery is to eliminate the mass effect and avoid ischemic injury. And I, as I said in my talk, I do have a concern about, putting new devices like flow diverters into a developing vascular system. We don't know what the long-term effects are. We definitely do know what the long-term effects of bypasses are in children. A number of them have been done. The youngest patient I ever did a saphenous vein bypass graft on was 1 year old. And I have almost 30-year follow-up on that. She's now an adult and has a saphenous vein that has become an artery. It's become arterialized over time. In a 10-year-old, I would likely use a saphenous vein. I like the radial artery better in adults, but I think in a 10-year-old, it may be a little small. That's kind of borderline. The case I showed was a 9-year-old with a much simpler cavernous aneurysm. But that's the way I treated it. I certainly don't want to give the impression that that there is evidence that putting an endovascular device in a child is going to lead to long-term consequences, but I just don't think we know. So my bias would be to do a bypass to replace that artery with a saphenous vein.
Robert, and what's your advice to Anthony?
Yeah, this is a tough case, and I agree with everything that's been said. I'm not entirely sure where the aneurysm starts and where it ends, but obviously you have to worry about the anterior choroidal artery in this setting. So
Anthony, sorry, Anthony, could you go back on the angiogram? Yeah, right, that's 3D. Yeah. What did you think, Anthony? The PCOM and the anterior choroidal, could you tell on that 3D where they're
right? Yeah, so that was an important part of my thought process, at least, was I couldn't quite tell where the PCOM was coming out, and kind of in terms of comparing evidence, if it's proximal to PCOM, then you can at least extrapolate a little bit aside from the age about from the PUFS trial results, or but even without that, the SENT trial would apply excepting for age. but yeah, it looked like it just reached PCOM, but not choroidal, but certainly like any endovascular option, like you definitely worry about gelling off the choroidal. I wanted to let Dr. Spetzler finish before I say anything.
You think the aneurysm stopped before PCOM?
It looked like it did. I know I'm not showing you all the pictures, but a lot of that is
I
just.
didn't see that on the angiogram, but that would be very important, obviously.
Yes.
So my treatment for this young lady, is it a lady?
Yes.
Yeah. Would be to do a short radial artery bypass from the facial artery to the M2 and occlude the internal carotid artery and do nothing else, and then repeat the angiogram. And if the aneurysm stops below the PCOM, it will disappear. If it is past the PCOM and there's enough flow through the PCOM, then something else may need to be done. But I'd like to do what is least invasive and has a good chance of success, and that's how I would treat this one.
Robert, you said facial artery. You mean internal maxillary artery?
Yes.
Okay.
Isn't the maxilla in the face?
Yes, but it has a different name.
Stop correcting me. You know exactly what I mean.
Details.
Yeah, exactly.
Dr. Spetzler, is there any consideration for which M2 you would bypass to?
The one that's easiest.
Okay.
Just the easiest.
So, yeah. So just moving along here, I'm really glad that you said that. Kind of like well before I got here, Neil Martin obviously informed a lot of the way that we do things here. But this patient came to us with a BTO. I don't always get a BTO in these patients. She passed, but so in general, I'll default to doing a bypass and a carotid ligation in the neck for things like what I remember. One of the things that Dr. Hiros warned me about was that if there's a strong PCOM, that a lot of the times these will continue to fill, just like you said. What should I perform any clip construct in order to address the mass effect immediately, and then should I do a clinoidectomy again to and would that help address the mass effect at all immediately? And actually, so I presented this with our neuroradiologist. We work very closely together, and in our multidisciplinary conference, and it was really interesting. Like they actually pushed very hard to do an open operation here, and the reason why is is kind of highlighted in this paper, where they compared the flow, with different types of stents, and whereas with a pipeline device they got a significant reduction in flow. They didn't see a commensurate reduction in pressure. It was the reduction in pressure was 8 millimeters mercury with the pipeline and only 4 millimeters mercury with the neuroform. And so for that reason, she's presenting with a medially pointing kind of like bulbous component and vision loss. They felt like her best shot at saving vision was an open operation. And so that's what I did here. Again, she passed her BTO, but the reason why I'm showing these pictures is because I was surprised at how much demand there was on just the STA. The cut flow index was greater than 1. You can see the flow 800 there is pretty brisk filling for just an STA MCA bypass to an M3 vessel. And so. On the left here, you can see the AP through a vert injection, and you can see there's some filling out in the MCA distribution. That you can see just a little bit of a shadow of what I'm going to show over here, and that is just that there is still some residual filling through PCOM of that aneurysm. For completeness sake, here's the bypass. Again, it shows kind of both proximal and distal filling, and then there's no flow across the ACOM or into the MCA segment. So, so luckily, her vision got dramatically better. Her visual field kind of improved to almost like 3/4 full out to the temporal side. So like my question now is, well, this was an immediate post-op angiogram. My question for the panelists, like, was the treatment choice appropriate? What could I have done better? And then, what should I do about this residual?
I think what you did was absolutely appropriate. And I would just, if you compare what is left and what you started with, it's such a small remnant. You've achieved the goal of your visual result. You just wait and repeat. I would personally follow her with MRI, MRA, as opposed to giving her more radiation at her age, but see what happens to the rest. I suspect it will disappear.
Dan, do you agree?
I agree.
All right.
Nice case, Anthony. Thank
for your
you.
advice.
Stacy, okay, go ahead.
Alrighty. So this is a complex case that for the students and residents going through, we'll kind of go through some collateral anatomy here. But this is basically a 68-year-old male who came in with subarachnoid hemorrhage, and it was primarily in the perimedullary and prepontine space. Severe COPD on oxygen at home has all of the risk factors one would expect in North Carolina. Had had a previous stroke with minor residual left arm weakness, but otherwise was intact. His scan looks bad, but he looks great. And so here you can see that he has, without the arrows, he basically has very thick subarachnoid clot around the brain stem, but nothing higher than that, nothing in the sylvian fissures. So this is where his clot is based. And this is the initial CTA here on the left. You can see by the arrow kind of this dysplastic vessel, maybe aneurysmal, maybe not, but there was clearly something there that wasn't normal. This is a teaser at 1 week that the subarachnoid hemorrhage has resolved at this particular level. And so I did the angiogram, and this is an AP left vertebral injection. And so we see two things here. By the upper arrow, there's this nidus of dysplastic vessels. And then by the lower arrow, there's this tiny 2 by 3 millimeter aneurysm with contrast stasis in it. And then there's some extra vessels that you wouldn't really expect to show up on your left vertebral artery run. And so here's an oblique, because of course, one view is no view. We're trying to figure out what's going on. And sure enough, again, I see this dysplastic kind of tangle of vessels, if you will. And then also, and that was at the level that I expected, kind of where I expected the blood to be. And a little lower down, we see this dysplastic aneurysm. And so, I went ahead to do, my big question, of course, I went into this thinking, is there a fistula, seeing kind of those extra weird dysplastic vessels there. But I have these two things. I went ahead and did the rest of the angiogram because obviously, one, we want to make sure we don't see any other aneurysms. However, there were a lot of vessels. And so he ended up having a right brachiocephalic occlusion at the origin. And because of that, he basically walled off his posterior circulation. His left vertebral artery ends in a giant pica, which I'll show you. And you can see here that he has his deep cervical artery is just really creating some pretty tremendous collaterals side to side. And you can see down below the inferior thyroid artery actually creates significant collaterals. That's how he fills his carotid circulation. So again, left vertebral artery, this is the early phase injection. You can see on the lateral that it ends in a giant left pica. You can see also kind of the little dysplastic vessels, anterior to that. And then you can see how what ends up happening is that you get anterior grade filling through side to side collaterals of the right vertebral artery, which then actually fills the posterior circulation. And again, just to show down low, this is where the brachiocephalic occlusion is. You can see the tremendous thyroid collaterals, and just to prove that, you know, his right side is not, nothing is really adding into the posterior circulation. So he's depending on those collaterals, certainly. And so here now at a week, we see the area of residual blood. And when you match up the different levels, you can see that down low, and that's kind of what these lines are pointing to, you know, at this level of the CTA, we clearly can see the aneurysm there. And then you can clearly see the dysplastic vessels at the level above that. The blood is a little bit higher than both of those things. And in this circle on the back of the CTA, you can just see, I mean, he really just has a lot of collateral muscular vessels keeping his posterior circulation alive. So, you know, for this particular patient, the question is, should we treat? Which lesion should we treat? And what are the surgical considerations? My partner, Dr. John Wilson, actually did a similar case pre-COVID that did not have a brachiocephalic occlusion, you know, and that aneurysm that you see kind of you know, in front of the brainstem there, that's clearly a surgical type of an aneurysm. There's no good endovascular thing. So, you know, how do you do that with and without this crazy occlusion in collateral arteries?
Stacy, may I say something? I mean, I have almost the identical case a few years ago. You remember Sammy, when Sammy was here in Miami with us and we did the case together. It was really an aneurysm between what I called it at the time, the collateral between the posterior spinal and the anterior spinal artery. And we did kind of a far lateral approach. More recently, it just reminds me your case of what's called the pure arterial malformation, PAM. Kind of like, it looks like an AVM, but there is no vein. And it goes along with an occlusion of the brachiocephalic, kind of this vigorous arterial formation that clearly causes stress on the wall and forms an aneurysm. So I think that's what it is. And I would explore it, and clipping obviously with intra-op monitoring like we did on that case a few years ago. But go ahead.
Would you have concerns about, you know, going far lateral? Obviously, that's the way to get to this. Do you have concerns about taking down the musculature, losing those collateral branches, being that he's not feeding, he's feeding his posterior circulation through his right vert, but that's feeding through the muscular collaterals from the left?
Yeah, good point. Are they crossing from the midline from the other side? Yeah. And
you can see kind of all of these, pick a level, but they're all crossing from left to right to then create anterior grade flow into the right vert.
Yeah.
Can you back up that one picture again? Yeah. Let's see. So your left vertebral artery is intact.
Yes. And the right vertebral artery is intact as well, but it feeds through the inferior thyroid into the subclavian and then retrograde. So it's a very slow and very delayed filling. When you do an arch run, the whole left side fills and gets into the venous phase before you see anything on the right.
But if you look at your right picture, the lateral vertebral artery, the collateralization really is all in the muscle. It has nothing to do with the intracranial circulation. The vertebral artery is going right up to the posterior fossa and filling it normally. And then you have the collateral off the vertebral artery for the muscles. This has nothing to do with intracranial hemorrhage. The aneurysm that you demonstrated so nicely, it's coming right off the combination of the anterior spinal arteries, I think is exactly as Jacques said, but I look at the internal, at the lateral intracranial vertebral artery injection to make sense out of those extra vessels. But you see what I'm talking about, those arrows?
these here. Yes, and there's no question. I agree. Intracranially, it looks perfectly safe. The approach that I would take to this is a far lateral, and my concern is that in taking down the musculature to perform the craniotomy, if I lose these muscular collaterals.
Stop a second. If you look at your left picture right here, where you have your arrow, where it says deep cervical muscular collateral to the right vertebral artery, why do you think that?
Following the runs, it's the deep cervical, and then it's also this vessel, which I will tell you, I don't know exactly. Maybe Bobby knows what that is.
These collaterals are not going to the vertebral artery, they're coming from the vertebral artery. Go back once more to the other picture, to the last picture. This, where you say deep cervical muscular collateral, they are not. They are just supplying blood to the muscles. You have a very good vertebral artery that is feeding the entire posterior fossa. And then when you look at the posterior circulation, you have to be sure you don't superimpose these muscular abnormal connections and think that they're intracranial. But where you show on that left picture, that is not feeding the vertebral artery in the sense of being necessary, because the left vertebral artery, which is usually dominant, is dominant here and has excellent flow to the posterior cerebral, to the posterior fossa.
Well, the left is actually non-dominant. It's the only one that's filling normally, but it ends in pica, and so the right.
How does that make sense if you look at the right picture?
Well, because
you see pica and everything else filling.
So the left, you can see here on the first picture, this is filling pica, and then the right vert starts filling anterior grade, but through the muscular collaterals from the left vert to the right vert. They cross midline, and then that fills the right vert anterior grade, and the right vert is what actually fills the basilar. The left vert does not fill the basilar.
Yeah, I see. Yeah.
It's a very bizarre. I mean, obviously, this is
I got you.
a way out of the box kind of thing.
Stacy, it's okay, just for the sake of time. Just can you move on?
Well, and that's basically this is one that we have not treated. He actually just came in just this past week. I spoke to him. He's made a beautiful recovery. Again, he's doing very, very well. And the question really comes down to, do I treat this aneurysm with a surgical approach there? And I don't know what the answer is yet.
Sounds like we all need more time to actually study those in detail. It's too complicated for a Zoom setting. How about we take a rain check on it?
That sounds good.
But thank you. Beautiful angiograms, by the way, beautiful details, and thank you. Okay, I've got a few questions from the audiences, and I know we're running late, so I'm gonna start just running them by you folks, and anybody who would like to answer, please do. I'll start with Najia El Abadi from Morocco, who's you all know, and she says hi. Her question, I think, to Robert was, I think you showed one with a fusiform or blister aneurysm with Gore-Tex around it, and you clip the Gore-Tex. Her question is that enough to protect future growth or future rebleeding from a blister or a fusiform aneurysm? Robert?
Yeah. It's actually Dan that showed that, but the only thing I would have done a little bit different than what Dan did is I would have put a little bit of cotton on it, since that comes from Georgia and Dan likes cotton. I'm very surprised he didn't use it. But yes, it works very well. The other caveat is I use a little bit thinner Gore-Tex than Dan did. The cardiologists have it, which is a little bit easier to manipulate. But yes, we've had follow-up, we've published it. That's a very nice way to treat blister aneurysms.
Yeah, I actually use the same thing.
We've done several long-term follow-up angiograms on them. I think that's really important, not just to ignore it. And this is the Gore-Tex that our cardiac surgeons use. That's where I get it. And I think if the patient presents with a subarachnoid hemorrhage, and there is evidence of some residual recurrence, then once the subarachnoid hemorrhage is resolved, then if a flow diverter or something is needed, then it's safer to do that with the dual antiplatelet therapy. But we've never needed to do that in the cases we've done.
Thank you. I'll go to a next question. How to improve the microsurgical skills of the young surgeons if they don't have cadaveric specimens available to them? Tough question, but anybody would, what advice do you, give people in places where there are no cadaveric labs?
Well, I think you could teach microsurgery in all aspects of neurosurgery. I think we conflate sometimes microsurgery with cerebrovascular clipping of aneurysms, but microsurgical skills make, in my opinion, all neurosurgeons better surgeons, whether you're a tumor surgeon, a spine surgeon, a pediatric neurosurgeon. I think learning to operate under a microscope, to use microsurgical instruments and deal with tissues just makes you a better surgeon. So you don't have to have just these kinds of cases to practice those on. Also, if you don't have access to a skull-based laboratory, certainly it's much easier to do microdissection in laboratories with models. There are beautiful models made where you can anastomose make-believe vessels together. You can do this on small animals, which are inexpensive. Certainly when I was a resident, I did lots and lots of rats to try to get good at microanastomosis. So I think there are ways to do it.
Robert?
I agree completely. I mean, there's so many models which have nothing to do with cadavers that you can do practice on. So yeah, there's no excuse to not practicing.
Something that's quick and easy at home is chicken wings. If you get a nice fresh chicken wing and you can get online a pair of castros and a fine forceps for very, very cheap, and then just keep using that suture over and over again.
Thank you. Opinion on treating some basilar trunk aneurysms endonasally transclavally, as has been reported in a few cases in the literature. Is that good? Is that bad? Advice from the speakers first and the panelists maybe?
I'm not really sure that it's good or bad. I think I know that at Case Western, Dr. Recade and I treated a anterior aneurysm right at the anterior spinal artery. And we went transorally and did a beautiful job, and we congratulated ourselves. And the next day out came the champagne because the kid was looking so well. 3 weeks later, he died from a basilar artery mycotic aneurysm. So when you can expose the vessels from a lateral approach that eliminates that risk to any segment of the posterior circulation, that would be my choice.
Actually, Robert, you reminded me, I was Alan Crockard registrar in the late 80s, and I assisted him. I was just his registrar doing that rotatable clip applier. Again, he did it transorally on 2 basilar tip, and actually both of them died with meningitis. Beautiful clipping, but yeah, it's interesting. Yeah. But then people talk about the bacteriologic flora is different in the mouth and the nose and so forth.
Yeah. No, it's true. One of the big problems is that you have the clip hanging out your right. Opening.
Right.
And then to get a good seal there, it's just, I will never forget that case. And if I can do it without going transorally, and I've done so many transoral operations for chordomas, etc. But only if truly there's no other option.
My next question from the audience is just perhaps general treatment guidelines for basilar dolichoectatic aneurysms. They're very difficult lesions. Anybody has a summarizing philosophy what to do with them?
My summarizing philosophy is I can name at least a dozen ways to kill those patients. I have yet to identify in my hands a method for treating those that I can confidently say is better than the natural history. We've all got I mean, those of us that have done this have those anecdotal successes that work well, the bypass to the posterior cerebral. But for every one of those, I can show you something that I've done that technically I thought went well, and it completely failed to control the disease. So I think it's one of the remaining challenges, and it's one of the things for which I pray we get a good endovascular option, because I don't think there are any great surgical options.
And while you're speaking, Dan, next question I'd like to ask you, because you have a beautiful presentation on it I've seen in the past. Just tell the audience members, how do you handle an intra-op rupture with a giant aneurysm? I know there are many sub-scenarios, but maybe give them some general pointers about intra-op rupture.
The best way to manage an intraoperative rupture is to prevent it. And the best way to prevent it, in my opinion, is to use sharp dissection. Almost every series will demonstrate that it's blunt dissection that transmits more pressure to the aneurysm and will precipitate a hemorrhage, whereas sharp dissection not only limits the complication, but if you do have one, it's easier to deal with. I think the second, when it does happen, and it's going to happen, I think the first step is to just keep your cool, not to, you know, you've got to not lose your composure. If the aneurysm is exposed at the time of the intraoperative rupture, generally that's something that can be dealt with pretty well. You can get proximal control, you can temporary clip or trap the aneurysm. The real problem is when there is a hemorrhage before you've actually exposed the aneurysm. And then you have to just follow the jet of blood with a high bore suction. As I showed in one of my cases, I always have a retractor ready. I rarely use it, but I have it for, that's one of the reasons, is that if you can tamponade the bleeding with a piece of fluffy cotton, not push it hard, but just put the retractor to tamponade it, that will usually stop the bleeding if it's on the dome. I guess the stepmother-in-law of all intraoperative complications is when you have a tear on the neck of the aneurysm, which when you try to clip it will compromise the parotid artery. And again, I give credit to my dear friend and mentor, Robert Spetzler, who together he and I were having a discussion about this one day and realized we both had used this technique and published it together. But to put a little piece of cotton on the tear and clip the cotton onto the tear will increase the contact with the tear and will maintain patency of the vessel and get rid of the tear in the neck. So those are some of the tricks to use, but I think probably the most important is not losing your composure, keeping your wits about you and figuring out how you can control the bleeding with temporary clips and then take care of the tear on the dome or the neck. Much easier if it's on the dome.
Thanks, Dan. And I think we'll finish with one last question. There are many more, but we can't keep going forever. And I really thank everybody for staying. We've got 400 people still online. So I think this is a good one. Essentially, maybe we can hear from both speakers. What's your approach to unruptured aneurysm? Can you both summarize to the audience when do you treat an unruptured aneurysm? Is it size alone, location? Just give us again a quick summary. Robert, maybe you could.
Yeah, I mean, that's a topic for itself. I think knowing what your endovascular colleagues are capable of and considering the age of the patient, the formation of the aneurysm, an unruptured aneurysm in somebody that's young, that's irregular, certainly ought to be treated. But I think each case is a case in itself. And I think what we showed in our presentations were really cases that did deserve treatment. But a small incidental aneurysm in somebody that's 75 years old, I think is best treated with watchful waiting. That same aneurysm in somebody that's 32 years old, may very well require management.
Dan, anything to add?
I agree with that completely. I think the overwhelming majority of unruptured aneurysms, in my opinion, don't need to be treated at all. And particularly in this era of modern imaging where they are identified very commonly when they're 2 millimeters, 3 millimeters. I think the things that I put into the calculus are factors of the patient. Robert mentioned it. The single most important is the age and the health of the patient, which is a surrogate for life expectancy. The younger and the healthier you are, the more dangerous the aneurysm is. And the other factors are family history, smoking history, perhaps hypertension. The factors of the aneurysm, size obviously is important, but also location. A 5 millimeter anterior communicating artery aneurysm bothers me a lot more than a 5 millimeter ophthalmic artery aneurysm, for example. And I think that configuration, it's a little more subjective, but you know, having looked at thousands of aneurysms under a microscope, when the angiogram shows a nice, smooth, round aneurysm, generally speaking, at the time of surgery, they look kind of safe. Whereas when they're irregular at the time of surgery, you can see the blood swirling, you know, through the aneurysm. So, so the first decision is whether to treat the aneurysm or not. Most of them, as I said, probably don't need to be treated. And then once you decide to treat it, I agree with Robert that whether we treat it by endovascular or surgical means is a discussion that's open and honest, giving the benefits and the risks of each of the options that might be available for that particular configuration of aneurysm.
On this note, I think we will finish this wonderful seminar. I thank, of course, Robert and Dan. I thank our co-directors and the 4 panelists. Thank you so much for taking time to reach out to such a large audience. And I see you folks next week for a bypass session. Thank you very much. Bye, everybody.